Right, thanks for joining me today. We're going to go over Chapter 9, which is in reference to therapeutic ultrasound. So this is something that we've talked about in our earlier semesters in our physics class when we were looking at waveforms and those different types of things related more to physics. But now we're going to dive into the details of the physical properties of ultrasound. We're going to look at the indications, the contraindications. We're also going to talk about parameters and how therapeutic ultrasound differs from something that you're probably more familiar with at this point, which would be diagnostic ultrasound or something that produces an image. So let's just look at the objectives for today. We're definitely going to discuss the different categories of physical agents and the role of each category in rehabilitation. So when we think about ultrasound, we're thinking that this is some type of mechanical agent. We're converting mechanical sound waves in our body into heat. And we'll talk about thermal ultrasound, we'll talk about non-thermal ultrasound. So we'll get into that a little bit. We're also going to define the different types of pain, including acute, chronic, and referred. That's pretty much a common theme for most of the objectives that we're going to see for all of our modalities. We're going to identify physiological effects of indications for contras for physical agents, like I mentioned earlier. We're also going to learn how to integrate appropriate evidence-based resources to support clinical decision-making for the selection of physical agents. And this is something that I really would suggest that you do, especially more so on your own time, looking into the clinical practice guidelines that the APTA has set for different types of diagnoses. They talk quite a bit about therapeutic ultrasound, the effects, the benefits, and whether or not you should really perform these activities or if you should switch away from them and do something more functional, things along those lines. In the lab, we're going to demonstrate interview techniques, obtain relevant information related to function, health status, and response to the treatment. We're going to select the appropriate and effective physical agents to achieve desired outcomes based on a sample plan of care. So we're going to look at a lot of different case studies and scenarios, at least in our lab, maybe not so much in this lecture. We're also going to demonstrate competency in proper, safe, and effective application of ultrasound. So learning when to select the correct parameters, learning when and how to identify those contraindications. We're going to determine when an intervention should not be performed due to clinical indications, when an intervention is beyond the scope of the physical therapist assistant, and when to report any changes in patient status or progress to the supervising physical therapist. And the last one we're going to be looking at today is just demonstrating safe handling, cleaning, storage, and maintenance of therapy equipment. So some of these are going to get in the lecture today. Some of them are going to be in the lab component. So let's look at this introduction to ultrasound. So on this slide here, I have a few different images. Looking at the top left corner to start with, this is probably something that you are more familiar with, and when you hear the term ultrasound, this may be the first thing that pops into your head. We're using a different type of therapeutic ultrasound in our classes, but the one on the top left and the one on the right-hand side would be more of a diagnostic ultrasound. So those are used to help produce images, take pictures, things along those lines. So obviously, looking at a baby in utero is something that you may be familiar with. On the right-hand side, the top corner there, we see that this physical therapist has dry needled this plantar surface of the foot. Maybe this patient has something like plantar fasciitis, but what's likely happening here, and this is becoming a little more common, at least in the state of New Mexico, PTs are able to use this diagnostic or imaging ultrasound to place these needles so that they have more specific placements and they're not just guessing based on anatomy labs that they've performed many years ago. So we can actually help guide those needles into the correct places where they need to be. And then finally, the one on the bottom right-hand side here is something that we're going to be performing in our lab settings and something that you're going to be skill comped over. This would be our therapeutic ultrasound. So we'll talk about maybe some of the differences between those different types. So I have this nice little table here for you that you should probably at least pay attention to. You don't have to star it because the parameters aren't very specific here. It just gives you a brief overview of some of the differences. But when we're using therapeutic ultrasounds, this tends to use lower frequencies, usually in that 1 megahertz to 3 megahertz range. It does not provide imaging for us to look at, but instead, what's happening is mechanical waves are converted into heat, or they create effects like tissue healing through cavitation. So those are some things that we're going to be discussing as far as our lecture goes today for therapeutic ultrasound. Whenever we are talking about diagnostic ultrasound, the ones that produce images, these ones typically use higher frequencies, up to about 15 megahertz or possibly more. And these sound waves are detected and reflected echoes, essentially, that are used to create images. And the intensity for these diagnostic ultrasounds are typically much lower. So we're going to use ranges anywhere from 0.5 to 2 watts per centimeter squared for our therapeutic ultrasound. The intensity that is typically used for something like diagnostic ultrasound ranges anywhere from 0.01 watts per centimeter squared to 0.1 watts per centimeter squared. So you can kind of just tell by the differences in the parameters, maybe how some of these different types of ultrasound differ. But I do want to just attract your attention to the mechanism of action, that third column down after, or really the fourth column down. But when we're looking at the mechanism of action, when we look at thermal ultrasound, we're using this thermal type to initiate deep heating, again via conversion of those sound waves into heat in the tissues. When we look at the mechanism of action for non-thermal ultrasound, we're going to talk more about acoustic streaming, cavitation. That's going to help create cell permeability, which is going to allow for nutrients to enter the area to help promote tissue healing. So we'll talk a little bit about those more later on in this lecture. So like I had just mentioned, we do have two different forms of ultrasound that we're going to be performing in the lab setting. The first one up top, thermal agent. This is used to target tissues with high collagen content, such as tendons, ligaments, joint capsules. And the thing that you have to understand is that tendons and ligaments are considered to have a pretty low specific heat, but a very high absorption coefficient, basically just meaning that they absorb this ultrasonic energy more efficiently than other tissues like muscle does. So we can target muscle bellies with thermal ultrasound, but it's not going to be as effective as if we target the tendons, let's say, of the rectus femoris, or the ligaments that help support these joint capsules. So keep that in mind for our lab situations. We're really looking at these high collagen content type tissues whenever we're thinking of heating them. This thermal type of ultrasound is going to help create tissue extensibility. So if you have a patient that is limited with range of motion, it probably wouldn't be best to go target the muscle belly of the rectus femoris. It's probably going to be more beneficial to get down to the musculotendinous unit and focus that ultrasound into those areas, because again, with these tissues with high collagen, they're going to absorb that energy more efficiently, and they're going to heat up faster. And when we apply heat to an area, we're creating this tissue extensibility, and we're trying to invoke permanent change in the length of these tendinous units. Then we get into non-thermal agents. We're not going to talk a lot about shockwave therapy. It's something that you'll see, I think, rarely in clinic. There's a few clinics around town here that do use shockwave therapy, but it's not considered to be one of the most common uses of something like sound therapy, but we are going to use non-thermal settings for ultrasound to invoke more of these different types of tissue healing. So we're going to, again, talk about all of these different forms or these physiologic responses that induce tissue healing, like cavitation, microstreaming, and those kind of things. So we're going to talk now about the physical properties of ultrasound. So these are terms that you definitely need to know, especially absorption and attenuation. We're going to discuss all of these, but those are the two that I really want you to know from this slide. When we discuss frequency, this is the number of compression rarefaction cycles per unit of time expressed in hertz. So I really want you to think of this as how many sound wave cycles happen every second. In the frequencies that we use for therapeutic ultrasound, it's about 700,000 to 3.3 million cycles per second. So, quite a few per second, obviously. When we hear the term absorption, this is something that refers to the conversion of mechanical energy of ultrasound to heat. So this is how the tissue converts ultrasound to that heat that we're talking about. And again, tissues with high collagen content like ligaments and tendons absorb that ultrasound energy better, which is why they heat up faster than something like muscle or possibly fat. Now we are going to talk about something that you need to look for as an adverse reaction. Burning, heating, significant heating of those tissues would be something that we want to be cautious of, which is why we're always going to keep that sound head moving over those certain areas. We're not ever going to allow it just to sit over an area because they're going to absorb that energy really fast. And we've talked already when we first discussed our specific heat in our lecture introducing thermal agents, that bone is also something that you have to consider and be aware of because it has low specific heat, just meaning that it heats up very quickly. It doesn't need much energy to heat up. So we'll talk about the risks associated with ultrasound a little bit later when we start looking at the precautions and the contraindications. But absorption is how we convert that mechanical energy into heat in the body. Now we talk about attenuation. This is the gradual loss of energy or intensity of a sound wave as it travels through a medium. So as ultrasound travels through the body, it loses energy due to scattering of those ultrasound waves, due to absorption from other tissues. All those other tissues, maybe more superficial, are absorbing that energy, which means there's less to get to those deep areas. And then reflection of those ultrasound waves. So again, we're going to talk a little bit more about those in just a second. But essentially what this means for attenuation is that those deeper tissues receive less energy compared to the superficial ones. That just means that we need to set the parameters correctly, increase the intensity, and then make sure that our patient isn't experiencing any of those adverse reactions that we don't want to see, like burning of the periosteum of the bone, or increasing the heat too intensely, too quickly in the collagen structures like tendons or ligaments. So here's a picture of what this attenuation would look like in the body. So we can see this high beam of energy as it leaves the transducer head, and then how it kind of fizzles out as it goes through these deep tissues. So just imagine, overlaying something like the biceps brachii really close to the transducer head. It's going to receive a lot of that energy, and as it goes through the body and it gets absorbed by certain tissues, you get less and less energy as it gets closer to the actual target source. So that's just a little visual for you on what attenuation actually looks like in the body. The next two that we're going to talk about are reflection and refaction. So what is reflection? Basically, it's when sound waves bounce back when they encounter a boundary between two different tissues. So just imagine these sound waves as a ball, and you're throwing it against a wall. Well, what does it do? It comes back when it hits a boundary. So think of this boundary as two different tissue types, essentially. Maybe we have soft tissue and we have bone. It's going to bounce back, right? Once it kind of passes through one of those mediums and it interacts with that bone. When it bounces back, this can create what we call standing waves, which are basically just concentrated energy that can cause hotspots. So this is what could lead to burning if we're not really careful and meticulous with the technique that we use. So we want to make sure to keep that sound head moving. Refraction is essentially the bending of sound waves as they pass through the tissue with varying densities. So muscle belly can be pretty dense as opposed to just skin or as opposed to adipose tissue. So it depends on the density, right? So different types of densities will bend those sound waves. This just means that ultrasound beam can change directions and it could possibly reduce that directed energy at the target site. So we want to be really aware of that. We may be getting less energy at the target tissue than what we thought due to this refraction. So again, just think of this, some key takeaways from this slide as with reflection, you always want to make sure that you're moving the ultrasound transducer to prevent those standing waves. We don't want to create hot spots in the tissue, which would potentially burn the tissue and lead to tissue damage. And we just have to understand that energy may not always go straight to the target due to this refraction. So proper positioning, technique, all those are essential for effective treatment. So now let's talk about how we can actually generate these sound waves with ultrasound. So basically what happens is inside this ultrasound machine, inside the transducer head, is a crystal that expands and contracts really rapidly whenever any type of electrical energy is applied to it. Sorry about that. This is called the piezoelectric effect, and it's how these ultrasound waves are generated. So let's talk about now compression and rarefaction. So basically what's happening with compression is these particles in the medium are pushed close together, and this creates a high pressure area. With rarefaction, the particles in that medium are now spread further apart, which creates a low pressure area. So the compression and the rarefaction create those sound waves that travel through the body to deliver those therapeutic effects. So I have a nice little image that you can look at here that kind of shows that. So you can see the compression where all those particles are really closely bound together, and that rarefaction where they're spread further apart. Those are what creates that wavelength. So this is a nice little image of what that compression and rarefaction actually are trying to show. So now let's introduce you to the different terms that you're going to be seeing for the parameters that we're going to select for specific intervention and treatments. So the terms that you really need to be familiar with would be intensity, which is represented in this watts per centimeter squared. We have the frequency, represented in megahertz. We have duty cycle, represented as a percentage. We have the effective radiating area, or the ERA. And then we also have what we call this beam non-uniformity ratio. So let's just kind of take a peek at this first one here. So this is a nice little slide that shows you those different frequencies that we're going to be using. Okay, so we're going to either use 1 megahertz or 3 megahertz with our applications. And on some of our machines, it'll say 1 or 3.3 megahertz. But those lines that you're seeing there illustrate the wave frequencies for therapeutic ultrasound. 3 megahertz is a higher frequency with closely packed waves, so basically a shorter wavelength. 1 megahertz, lower frequency with more spread out waves, so it's a longer wavelength. Now, how does this really affect our treatments? Well, with the 3 megahertz, or that higher frequency, this penetrates into the shallow tissues up to about 2 centimeters. Okay, so not very deep. It's ideal for areas like tendons and ligaments that are near the surface of the skin. When we look at the 1 megahertz, this is a lower frequency. This is the setting that we're going to use to help get deeper into those tissues, so up to about 5 centimeters in depth. This is usually best for larger, deeper muscles, joints, tendons, ligaments that lie below that kind of superficial area of the skin. So we have this nice little image straight from your textbook here. You can see, again, just by the length of the arrows, that 3.3 megahertz, that 3 megahertz, the high frequency, is going to travel into the superficial tissues, but not going to be very effective at getting into those deeper tissues, whereas the 1 megahertz is going to target some of those deeper structures. So if you just think back to our anatomy class, and I know looking at the forearm was a little bit rough for you all, but you're going to have to get back in and look at those different structures, because we're going to ask you to identify which parameters to use based on what we're targeting in our treatment. So if you think of that common extensor tendon on the posterior side of the forearm, we're going to target that structure with more of a superficial setting, 3.3 megahertz. But if we were trying to get deeper into some of those different layers beneath those superficial muscles, then we're going to use something like a 1 megahertz. Let's say we're trying to get close to that radial head, right? We're trying to target ligaments and tendons surrounding that radial head. You can find it fairly easily if you come just inferior off that lateral epicondyle, and you can find the actual head, which is a little bit superficial. So you can go there, but just beware that you're going to get quite a bit of that reflection, right? Because we're going through muscle tissue, we're also going through, we're hitting bone tissue after we get through that muscle tissue. So that may cause those standing waves that we talked about, creating hot spots. So you could also go through the muscle belly kind of on the more lateral side of the forearm, maybe through that ECRB, the brachioradialis. You could try to do it that way too, but if you did that, you would have to set more of a deep setting, these low frequencies, the 1 megahertz, to get through all of that muscle tissue. So there's benefits to doing both of those. You just have to consider all of these different factors that are going to really affect your treatment. Are there going to be reflection or standing waves due to different types of tissue, different densities of the tissue? We have to think about that. Okay, so we'll do more in lab. We'll discuss what I think is best, just as my opinion, and then we can kind of move on from there. Now let's talk about that effective radiating area, or the ERA. So why is the ERA important? Well, if we look at the definition of this effective radiating area, it's the portion of the ultrasound transducer face that actually produces ultrasound waves. The portion that actually produces these sound waves is smaller than the physical size of the transducer face, because not all areas of that transducer generate sound waves effectively. So what kind of significance does this have with our treatment? Well, the ERA determines the size of the treatment area, and we don't really want to move outside the treatment area. What we can do is we can move about 2 to 3 times the size of the ERA when we're locating an area that we're going to treat. So if you have, let's say, this ERA of 5 centimeters, you can only move about 10 centimeters to 15 centimeters max for the entire treatment area. So we're looking at localized small areas of the body in order to really effectively heat it or produce those tissue healing responses that we're looking for. We can't go up the entire length of the lateral forearm, or we can't use ultrasound the entire length of the rectus femoris or the whole entire quad muscle group. because it's not going to treat it very effectively. So we have to think about the ERA. If there's a larger transducer head, then we can target a larger area. But if we have a small transducer head, then we are obviously going to be limited to an area that's much smaller. And it just matters because the consistency and understanding the ERA helps deliver that treatment, right? If we're targeting a small area, we don't want to move outside of that effective radiating area. We want to keep it pretty confined. So now let's look at this beam non-uniformity. Okay. So some things that we need to look at on this slide and kind of understand is the very top where we have this red dotted line called the spatial peak intensity. This is the highest intensity of the ultrasound beam at any point, okay, represented by those tall peaks on that graph. Hotspots can occur if that transducer head is not moved properly, as this is where the majority of that energy is concentrated in those areas. Then let's look at the spatial average intensity, this green dotted line here. So this is the value you set on the ultrasound machine. This is basically the average output that you're getting through those tissues. Okay, so beam non-uniformity ratio measures how much that spatial peak intensity deviates from that spatial average intensity. And that's pretty much all you need to know about this one. But just knowing, as you can see, the middle of that transducer head is where the most effective sound wave and energy is going to be transmitted. So we want to try to keep that area, we want to try to keep that portion of that transducer head pretty consistent over the treatment area. We definitely don't want to sway too far outside of it because you see that intensity really drop when we get closer to the edges of that transducer head. So we want to make sure that the middle of that transducer head is always pointed at the target area. Okay, so now let's start looking at these different types of ultrasound that you're going to be responsible for learning, knowing about for quizzes and for your testing purposes. So let's start with the thermal effects of ultrasound. So we kind of briefly had talked about this with our introduction in the lab setting. But whenever we're using thermal ultrasound, we're going to choose a duty cycle of 100%. That means that the entire treatment time, if we set it for 8 minutes, our energy, the sound waves are going to be produced the entire time. It's not cycling off or cycling back on. It's going to be 100% of that time energy is being delivered to those tissues. So again, you just have to think about the reflection and the refraction. So again, remember that the reflection increases that transducer to heat up substantially. We have to think about this air-skin interface. So for any ultrasound application that you're going to be performing, we're going to use this nice gel on the surface of the skin and between the transducer head and the skin. And the reason that we need that is because, like I was just talking about, this air-skin interface can cause reflection, which can cause those standing waves, and it can actually cause the transducer to overheat, which is obviously a burn risk. So we need to make sure that there's sufficient amounts of that gel on the skin. And if you ever need to pause the treatment to add more gel, that's perfectly fine. You just need to make sure that the actual transducer head is not producing sound waves whenever you're taking it off the skin. And you also want to make sure that you're not just leaving it directly on the skin while the energy is being produced and passed into the skin. Again, we have to think about this refraction. Okay, this happens when sound waves bend as they pass through tissues of different densities. We have to be aware of that. This can cause some of that ultrasound energy again to travel to tissues not directly targeted. So we have to be really precise with our treatment. Okay, and just to go kind of back to the first point of this here, the continuous ultrasound, that 100% duty cycle, just remember that this means that the ultrasound waves are delivered consistently without any pauses. This is what causes that thermal effect or that heat generation. And remember, this type of ultrasound is really used to help increase tissue extensibility, usually before stretching or concurrently with stretching. We can reduce muscle spasms using this thermal effect and increasing blood flow to the area. So all of those would be something that, all those indications would be something that we'd use these thermal effects of ultrasound for. So still looking at the thermal effects of ultrasound here, just remember that anytime we're discussing therapeutic ultrasound, we're really trying to target those high density collagen tissues because they have that high absorption coefficient. So scar tissue is something that we can definitely target because it's very dense collagen, so that means it's going to heat up quickly. If somebody has significant amounts of scar tissue in the area, that can limit their mobility. It doesn't have as good elasticity as normal healthy tissue, so maybe we want to heat that tissue, perform stretching or some kind of tension to that scar tissue to help it remodel, to help it gain elasticity. So that would be a great indication for using something like thermal ultrasound. The only thing that is a little tricky is that you can't use it on every scar that you see. We'll look at the contraindications later, but if somebody's had some type of surgical intervention like a total joint replacement, we really want to stay away from those areas with thermal ultrasound. And again, we'll talk about why we want to stay away from those here in just a little bit. As far as factors that affect the amount of temperature increase, the number one thing, well, really two things that affect the amount of temperature increase is the speed at which you move that transducer head. So if you're just putting the transducer head over an area and you're not moving it, there's more of a chance that you're going to concentrate heat into one area, which can cause overheating, discomfort, burns, things along that line. So we also don't want to move it too fast, even though that's going to help distribute the heat better. We may be reducing the total therapeutic effect of those tissues, so we want to make sure that it's nice and controlled movements. We'll talk about the speed at which we want to move those, or move that transducer head. So we don't want to move it too fast. We obviously don't want to move it too slow. We want to kind of have somewhere right in the middle. The other thing that affects the temperature increase is the intensity. So that watts per centimeter squared that we were talking about. A stronger output of energy leads to more heat. So if you really crank that intensity up, just be aware that there's a higher risk of burning some of those tissues in the area. So really important with higher intensities that you keep that ultrasound head moving and that you're trying not to create those standing waves that we talked about that happen with reflection. So what to expect as the patient? Well, you should tell your patient that because you are using this thermal effect of ultrasound, that they may feel some warmth. Now, there are some transducer heads that have a heating mode on it, so it just warms the head of the transducer. I like to keep that off because I want them to actually be able to tell me if that ultrasound head is warming up due to this reflection or this refraction that's occurring. I want them to be able to sense the heat without kind of just without introducing it beforehand. So I typically leave that head warmer off. I just want them to feel the actual warmth from the head of the transducer. Also, you have to be very, very cautious and careful. If that intensity is too high, your patient may complain of a deep ache from overheating of the periosteum. So we don't want to burn the bone by increasing the intensity too much or creating those standing waves. So just remember that bone also has a very low specific heat, meaning that it does not take a lot of energy to heat that up. So we have to be cautious. We have to let the patient know that, yes, it's okay to feel warmth in the area because we are using thermal ultrasound. We are creating heat, but we want them to be aware of this kind of deep aching sensation. If they start to feel that, they need to tell us right away because there's a chance that we're burning the periosteum of the bone, which is no bueno. All right, so now let's move on to the non-thermal effects of ultrasound. So when we're looking at the parameters for ultrasound, we saw for thermal ultrasound, we're going to use a duty cycle of 100%. Whenever we're trying to initiate these non-thermal effects of ultrasound, we're going to set that duty cycle at 10%, 20%, 50%. Those are kind of the typical ranges that you would use. So basically this just means that ultrasound delivers energy intermittently. So basically we have on-off cycles, and that helps to limit any kind of heat production in the area. And this mode is going to typically help us focus on cellular tissue changes rather than just raising the temperature of the tissue. Now when we look at stable cavitation, this causes the formation of vibration of gas-filled bubbles in the tissues, which leads to different pressure surrounding those tissues, and it helps to enhance cellular activity and improve the exchange of nutrients and waste in the tissues. So we're trying to increase, essentially what we're trying to do is increase cellular permeability here. This is going to, again, allow those metabolic waste products to exit the tissue and allows the exchange of new healthy nutrients to enter, which is going to help improve our tissue healing response. You may have heard something like microstreaming before in the past, but let's just talk about this one here really quickly. So acoustic microstreaming refers to the steady circular movement of cellular fluids caused by those ultrasound waves. And the effects are that it creates that cell membrane permeability again, which improves nutrient delivery and waste removal. So non-thermal ultrasound is all about increasing cell permeability and getting that exchange of nutrients while getting rid of that metabolic waste in the tissues. We're trying to facilitate tissue repair by enhancing these cellular processes. So let's look at what that really looks like on a cellular level, at least so you can just visualize it. So you can see that we have stable cavitation kind of right in the center here. And again, those are those small gas-filled bubbles in the tissues that oscillate, so they're growing and shrinking, but they are not collapsing. We'll look at what that is here in a second. When these small gas-filled bubbles oscillate, when they grow and they shrink, this is what creates those microcurrents or that microstreaming effect, which improve the flow of those cellular fluids and again increases cell membrane permeability. This helps to again enhance nutrient exchange and waste removal, supporting our tissue healing. If we do look at the very bottom of this image, this would be an example of what unstable cavitation is. We get this implosion. And basically what's happening with that is it's vibrating too quickly. It's when it does implode finally, it releases free radicals. It creates this rapid increase in temperature and pressure. This can damage the tissues, and it's something that's undesirable in clinical application. So in order to prevent that, we just have to make sure that we have the proper settings, we have the proper technique, so that we can avoid something like that implosion or that what we call unstable cavitation. Stable cavitation is something that we do want. So we've talked a lot about cell membrane permeability and how it's a desired effect for this non-thermal application of ultrasound. But what does that really mean? Well, it means that when we're increasing cell permeability, we get things like these mast cell degranulations, which help to release substances like histamine and chemotactic factors, which play a role in that inflammatory and healing process. We've kind of learned about what chemotaxis is and why histamines are important to help vasodilate certain areas. This also helps macrophages enter the area and their responsiveness, so it improves the activity of those macrophages. And remember that those are just there to help remove damaged tissue and promote repair. It stimulates cells to produce proteins essential for tissue repair, so that protein synthesis. It stimulates chondrocytes or cartilage cells. It also helps with nitric oxide synthesis, which helps to promote the production of blood flow and cellular signaling, and again, increasing blood flow. So we can get all of those responses through this cell membrane permeability, which is only really possible through that cavitation, that stable cavitation form. All right, so let's move on to the indications. We've kind of briefly mentioned some of these indications for ultrasound already, but when we're using continuous ultrasound, aka thermal ultrasound, we're going to use this before or during stretching of these shortened tissues. So if somebody has decreased range of motion, that would be an indication to use something like thermal ultrasound, as long as you've already ruled out all of the contras, and also to help reduce pain. So we talked about ischemia and how that causes pain. So increasing blood flow to certain areas can help to relax the tissues. You know, if you have something like a trigger point or something like that, so any kind of adhesions, things like that, we can deliver blood, we can heat the tissues, we can reduce pain in those different forms. When we're using pulsed ultrasound, why are we going to use this? Well, we're really going to use it to help accelerate tissue healing. We can help modify inflammation. We just saw all of those different responses that happen due to increased cell permeability. We get all of those histamines into the area, we get all the macrophages and that response going. So we can kind of modify that inflammatory process by creating cell permeability by using stable cavitation to help modify that cellular process. And with pulsed ultrasound, we can also facilitate transdermal drug penetration via phonophoresis. So we're not going to look at that. We've kind of briefly mentioned that in our lectures. But if you're using something like, let's say, dexamethasone to help decrease inflammation in the area, we can apply that to the skin. Basically, they're going to inject that medication into the gel that we're using, and we're applying to the skin in the ultrasound head. And then we use this pulsed ultrasound to help drive that medication transdermally through the skin to reach those different tissues that we're trying to target. So there's a ton of different drugs and medications that we can use with this kind of pulsed ultrasound in the form of phonophoresis. So again, here's the clinical indications for ultrasound, just in a little bit more of a listed format here. So you may want to just look at those and be familiar with the most common ones that we're going to be using. Now let's look at these contraindications and precautions. We want to really make sure to star this slide to know these for any type of testing, whether it be in the lab setting or a written exam. So let's look at the contraindications. We have malignancy, any type of heat application to the area is going to increase metabolic rate. That's not a good thing, especially if we're going over malignant tissues. We don't want that to metastasize. We're going to stay away from the abdomen region. I would even stay away from the posterior portion of the spine if somebody's pregnant. We don't want to heat any of we don't want to cause any heating deep into the tissues whenever there's a fetus present. We don't really want to mess with that development at all. So we're going to stay away from that area with our women who are pregnant. We're not going to go over any CNS tissue. So the thing that you'll see on the lab handout that we have is a common question that you can ask your patients is, have you ever had a laminectomy in these areas above L2? With that laminectomy, they're taking out a portion of that, they're taking out the lamina of the spine in certain areas, and once that lamina is gone, we have exposed CNS tissue now. We don't want to go over, we don't want to use ultrasound in those areas where they possibly have had a laminectomy because that CNS tissue is now exposed. We want to ask our patients if they've had a joint replacement or any type of surgical intervention where they've received plastic components in the area. We're not trying to heat that joint cement. We're not trying to heat the plastic components. That could cause those structures to fail, and they may be going back into surgery for a revision of that initial surgical intervention. So we're going to ask if they've had joint replacements, if they know if they have any plastic components in the area. We're going to ask them if they have a pacemaker or any type of implantable cardiac device. We're not trying to mess with that either, so stay away from those. Thrombophlebitis is another big one that you're going to see that repeats on a lot of these modalities and contraindications for these modalities. So ask them if they have any vascular issues that causes thrombophlebitis. Ask them if they've had any history of blood clots or if they know they have any blood clots currently. And then the last one here is we're going to stay away from the eyes and the reproductive organs. Some of the precautions that you might want to use would be acute inflammation. If somebody has acute inflammation, it's not a for sure no, we can't use therapeutic ultrasound, but we're going to use the correct form. We're going to use a non-thermal form to maybe modify inflammation, but we're not going to use thermal settings. We really want to stay away from the growth plates in young children. We don't want to stunt their growth or have any effect or injure those areas at the growth plates. So typically I would stay away from ultrasound for younger patients, especially if you're at the end of those long bones. If you have fractures, this is typically something that we're going to stay away from with ultrasound. Even though there are parameters to help induce bone healing, it's something that we're not going to be performing in our lab setting. So if you're curious about that, you can always come ask me more questions. You can do a little research on your own. But there are certain instances where you would use ultrasound to help stimulate bone healing. And the other thing, the last one here would be breast implants. So staying away from any tissue or any tissue that's surrounding the breast if somebody has a breast implant. Again, we just don't want to heat up anything internally and cause it to fail. Some of the adverse effects that you want to be aware of. Burns especially is kind of the big one here that occur with thermal application. So let your patient know that this should be warm, it should not burn. You should also not feel this dull aching sensation because that again is at a risk for periosteal burning. Typically burns are rare, but it is the most common adverse effect for ultrasound, and we really want to be cautious in areas where there is impaired circulation or sensation. Just remember that if we have impaired circulation, we may not be able to disperse that heat as effectively as we typically would with normal circulation. Same thing goes for sensation. We want to be cautious there. We don't want to burn our patient and not know about it just because they have poor sensation in that area. We want to limit the amount of standing waves through that reflection cycle. So positioning, understanding of the different types of tissue and the tissue densities is going to be important. If you're near bone and you're targeting soft tissue, you want to be aware of that. You may want to stay away from it to limit this amount of standing waves. And then the last one here, cross-contamination or infection. Make sure you clean your equipment. We're going to clean it every single time that we use it before we apply it to our patient. We're going to clean it every single time once we're done with the application of ultrasound. But, you know, just a rule of thumb, just assume that everything is cross-contaminated already. It's already infected, so we're going to clean all of those different surfaces that are touching our patients, especially if you're going to use it near an open wound. If you're trying to induce soft tissue healing, you want to be really, really cautious there. So take the precautions you need, wash your hands, clean your equipment. Okay, so we're going to actually just move past this slide here because I want to show you this last little piece. This is probably going to be your best friend when learning these parameters for therapeutic ultrasound. This table is great. It's in your book. You can check it out. But I like it because it breaks it down into essentially two main columns. So we're looking at, on the left-hand side, essentially thermal application of ultrasound, and on the right-hand side, non-thermal application of ultrasound. So let's look here really quick. We can just go from the top on down. So why would we use thermal ultrasound? Well, typically the main reason that we're going to use is because there is some kind of soft tissue shortening going on, and we're trying to increase the heat to improve elasticity and maybe help stretch that patient out. So you see an impairment, soft tissue shortening, you're automatically thinking thermal ultrasound. That means that you're going to set the duty cycle at 100%. And then from there, you just have to make some decisions based on, you know, your own clinical reasoning. So what is the depth of the problem? Is it superficial, as in 1 to 2 centimeters deep off the skin, or is it close to 5 centimeters? If the depth of the problem is 1 to 2 centimeters superficial, then we're going to use the frequency of 3 megahertz. If the depth of the problem is greater than 2 centimeters, then we're going to select the frequency at 1 megahertz. So let's go back to the superficial side here and look at the intensity. So we've established that the depth of the problem is 1 to 2 centimeters. We've selected 3 megahertz as our frequency. Now we have to set the intensity. So 0.5 watts per centimeter squared is where you want to stay for this one. If the issue is not deep, then we don't need to increase the intensity. The intensity increases whenever the depth of the problem is greater than 2 centimeters. So if we did select 1 megahertz for the frequency, because we know that this is a deep structure that we're trying to target, we're going to also increase the intensity. Remember absorption. So as that sound wave travels through the tissue, those different structures along the way are going to absorb some of that energy, and also think of the attenuation. As that sound wave travels deeper and deeper, it becomes less intense. So in order to kind of counteract that, we need to increase the intensity so that we can actually deliver energy to those deeper tissues. Okay, so 5 to 10 minutes, essentially for 2 times the size of the ERA. So the 2 times the size of the transducer is what we're looking at, 5 to 10 minutes. Okay, so that's the kind of whole thermal side. Let's look at the other column where we look at impairments, and it says delayed tissue healing, or there's prolonged inflammation. So if we see any of those in our materials, then we're automatically thinking we're going to use non-thermal settings. The duty cycle that they recommend here would be 20%. Just remember that it could be 10%, 20%, or 50%. So we're selecting the duty cycle, 20%, because we've established that we're trying to initiate tissue healing or we're trying to modify inflammation. And then we go through the same process. What is the depth of the problem? Is it 1 to 2 centimeters or is it 5 centimeters? 1 to 2 centimeters, we're going to select that 3 megahertz. Greater than that, up to 5 centimeters, we're looking at 1 megahertz. this is the nice part about this table, is that you can start your intensity anywhere from 0.5 to 1 when we're looking at non-thermal application. So any of those ranges would work just fine. But we're not going to increase the intensity, because remember what causes heat in the tissue? Well, it's increasing that intensity too much. So we're trying to keep that intensity low so that we're not affecting the tissue temperature. We only want to set it at 1 watt per centimeter squared at max. Okay? So I've looked at this table a million times. It all makes sense to me, but you need to study this table. You need to make it make sense to you. The easy way to think about it, again, is if you are going deep into the tissue, you need to increase the intensity. I think the intensity is the hardest parameter for students to remember. Not so much the duty cycle, not so much the frequency, but once they get to the intensity, you can see them start to sweat a little bit. So if it's deep tissue, you're going to increase the intensity, especially if you're trying to initiate more of a heating response. Remember, intensity increases heat. So if you're not trying to increase heat and you're trying to do something like promote tissue healing instead, you're going to turn that intensity down, right? You can see it doesn't even get to that 1.5 that we're looking at for deep thermal settings. So 0.5 to 1, because we're not trying to increase tissue temperature. I know this can be a little much to memorize. If you're having troubles, please reach out to me directly. The last little component here discusses documentation. So here are some CPT codes for ultrasound and for phonophoresis. You can see that CPT code is the exact same over here, 97035. These are both timed units, so you get essentially paid for every 15-minute increment starting at 8. So it's not a one-time code. You can bill multiple units per day, whereas if it's untimed, you can only bill 1 per day. And then you can see the common usage for ultrasound: deep tissue heating, extensibility, pain relief, add in soft tissue healing or modification of inflammation. With phonophoresis, just remember that we're delivering medications transdermally here. And that brings us to the end of our lecture. I really hope this was helpful for you. If you need any more advice on how to study for therapeutic ultrasound, reach out to me. But again, hopefully this was very helpful. Thank you so much for listening, and I will see you soon.